So, so that's kind of where we are with standard treatments, but you know, we're here at ASH and we're going to hear a lot of new drugs that won't have names, they'll have letters and numbers. And is there anything out there that is really striking your interest? And I'm going to start with Elias because I brought up the issue about the post-AZA and post-decitabine failures. There is a drug that's being developed exactly in that niche. You want to tell us more about that?
Yes, one of the drugs, the polo-like inhibitor, rigosertib, the drug has been assessed in AML, in MDS, low risk, high risk. We're all awaiting the final result of a phase 3 trial, registrational study, in patients who failed hypomethylating agents and were randomized to either Onconova or rigosertib versus low-dose RSC. We're awaiting the results. The study has finished the accrual, and hopefully we can hear soon the results. And if it's positive, then we have a new lead post-hypomethylating agent failure. There will be another drug presented by Guillermo Garcia Manero and Rami on Monday as well, RS614, for patients with low-risk MDS, transfusion dependent. We've seen good responses, patients becoming transfusion independent. That is a new lead as well in patients with a low risk, whose main problem is transfusion dependency.
Rami, you want to say a word about that agent?
Right, so RA614 is a P38 MAP kinase inhibitor. It's thought that this pathway is like a convergence pathway that many of the cytokine signaling go through. There was a prior compound tested from SIO that was not later developed, but there were responses seen there. This is the second kind of phase 1 we run with this drug that this was a better formulation of the drug for the kinetics, but the first phase we saw almost somewhere between 30 to 40% responses. Interestingly, in all patients that had prior hypomethylator therapy. So that was kind of an interesting observation. Some of those responses are tri-lineage. Now this is obviously phase 1, so one should not make much of the efficacy. But there are tri-lineage responses. What strikes me treating patients on this trial that we saw neutropenia and thrombocytopenia responses like with this treatment and relatively well-tolerated therapy.
Well, that's exciting. I mean, that we're starting to learn from the biology of the disease and starting to target pathways. Mark, so any other examples?
Again, I think the whole genome sequencing of this disease has highlighted an old enemy, the P53 pathway. And the pharmaceutical industry and academia are finally really turning their attention to addressing this. Now, this is sort of, in the not immediate future, but perhaps 3 to 5 years from now. Trials are going right now on modulators of MDM2, which is a P53 inhibitor. Addressing P53 mutant disease is going to be more challenging, but in fact, all of these agents are coming into play, and I would point out that heme malignancies is often the fertile ground for getting responses where you don't necessarily see that in solid tumors, so I would be anxious to see us win that moon race, if you will. So I think that's has, if anything, the most potential of any of these agents.
So the idea there is P53, the protector of the genome, can be downregulated, moved out of the nucleus by binding to MDM2. And these drugs interfere, these are small molecule inhibitors that interfere with the interactions?
They do. I think actually the fact that we found these abnormalities makes MDS look more like the solid tumors. That's a feature of solid tumors, right? P53 knockout. P53, it's something that interferes with that pathway. So you can either use a small molecule inhibitor preventing the MDM2 from keeping P53 from doing its job. Alternatively, you can try and modulate bypassing the fact that you've lost P53. This is going to be much more challenging. Unfortunately, that's going to be a bigger hurdle.
Yeah, and the other part of the story, it's a very complex story, and I'm not expert in P53 by any means, but in deletion 5q particularly, there is actually the other part of the story that actually P53 is overexpressed in patients with deletion 5q, preferentially in the erythroid lineage, due to the haploinsufficiency of the RSP14 gene, and then they thought that even something like lenalidomide will work by stimulating MDM2, binding the p53 and degrading it. What we've seen at time of response, that the p53 expression in the erythroid cells goes down, and time of resistance it comes up. And we actually presented some data last year on adding things like dexamethasone to downregulate p53. We gained some of those responses back. We are moving forward with studies that can, target the p53 downregulation. But that's a very kind of tricky way in a way, because like on the other hand of the story is what Mark was alluding to, is like also sometimes downregulating p53 could not be a good thing in terms of progression of the disease. So one have to be very careful about the balance there.
I think that highlights one of the main points, that some of the therapies are really directed at the abnormal clone and try to eradicate the disease-maintaining cells. Other therapies are really designed to get the most that we can out of that abnormal clone without necessarily trying to eradicate it. If we can get those abnormal cells to differentiate into mature red blood cells, platelets, and neutrophils, then we've done our service to our patients. So some of the therapies that we have are really aimed at being stem cell toxic or disease cell toxic, and others are really pro-differentiation agents.
Trying to reason with the disease rather
They're
than
probably
fight.
going to be used in different scenarios. So these p53 mutant patients or p53 downregulated patients that we worry about are the high-risk patients that are likely to transform. The lower-risk patients, like the del5q patients, that may actually have p53 working against them, driving some of the destruction of the maturing cells, may be the place where we actually try to move that pathway in the other direction.
Perhaps I might highlight at this meeting as well. I mean, as we look at different themes, targeting completely new pathways, another theme that I think is going to be discussed at this meeting is, are there more ways that we can get out of hypomethylation? In particular, I think one of the more interesting is with the trials with the oral azacitidine. I mean, I think if we look at that agent, as we've employed it in many patients, it's been beneficial. It's probably been the most active class, but clearly, one, tethering patients to have to be coming in for an infusional therapy has a negative component. And two, to some degree, it has limited the ability to, let's see, a bit more creative in terms of dosing and scheduling. I mean, there have been trials comparing 7 days versus 5 days, but truly there are many different schedules that one could be explored. So the oral azacitidine studies are going to be updated in individuals who have RABE1, RABE2. I think are illustrative for a couple reasons. One, the fact that the drug can be given orally, clearly at higher dose to adjust for bioavailability, and it remains active, and it can help patients. I don't think we yet fully know, does that mean the equivalent for these same patients as the infusion or subcutaneous hypomethylation therapies, but that certainly is a possible hope. But it might well open up the door to combination therapies in a more practical approach, as well as alternative schedules that clearly would be much more patient-friendly. I mean, clearly if a purely outpatient therapy that is oral, whether it be single agent or combination, would be vastly superior for patients in terms of, if nothing else, the hassle factor and its impact on their health-related quality of life. So very interesting. Again, probably won't be transformative, but might be very helpful in transitioning hypomethylation as being a key part of combination therapies for the future.
Well, that raises an important point. There are many in the field who feel we have not gotten the maximum benefit out of the current hypomethylating agents. I mean, Yogan Sarantaraja will tell you we're not dosing decitabine correctly, and in fact, we need to dose it at lower levels to have its full differentiating effect. And he may well be right. I think those studies are actually ongoing.
To mention the dose schedule, we're not dosing very well. We're going to low-risk MDS patients in whom we really something with trigger therapy, and we're trying a lower dose schedule. For example, decitabine, instead of giving 5 days, we're giving 3 days. Yeah. We did a phase 2, we published in JCO that it can improve cytopenias, and now we're moving with the MDS consortium, including Hopkins and other centers, to enroll patients with low-risk MDS, rather than we know if we watch and wait, we don't help them, to start with a lower dose schedule and see in a prospective way whether we can improve their count. And at the same time, in a prospective fashion, we're checking for close monitoring to see how the new mutations will play into the treatment of these patients.
And again, this could be a huge thing if you could find that, almost seemingly homeopathic dose. Yogan will tell you it's not homeopathy at all. It's actually the way it's supposed to work. You could have a big impact on quality of life of patients that are getting these agents chronically, almost like oral Vidasa would do.